Chair will recognize the gentleman from Arizona, Dr. Gosar.
Thank you. Ms. Klein, why do we have so many emergency visits? Why are we stacked up in the emergency room?
I'm sorry?
Why are we all stacked up in the emergency room? I mean, you know the facts and figures.
Well, there are lots of people who use emergency rooms for a lot of different reasons. Many of them have actually emergencies.
Oh, yes. But, I mean, but we're seeing an undue thing. And let's kind of go to statistics. We can make statistics do anything we want them to, okay? Wouldn't you say the #1 reason we have a problem in our emergency room is that we're lacking family docs?
You know, actually, I do not know, because I'm not an expert in sort of how the healthcare system is divvied up. I know there are certainly shortages of providers in certain areas of the country. That's true across the healthcare sector.
It's pretty much. But the #1 reason why we don't have family docs is because of unfunded mandates. Is that true, Mr. Botsko?
Thank you for the question. Regarding whether that's the reason, I'm not really at liberty to say. That's not my specialty.
But one of the unfunded mandates is that we're asking providers to do more and more with less, and they're not actually seeing patients. And so the only recourse patients have is to go to the emergency room.
And yes, sir, we certainly are being asked to do a lot more with a lot less.
Can you tell me some of the strings that are attached with the Federal money for Medicaid money?
Some of the ones that we're seeing are the unfunded mandates where we're asked to go out and do site visits, and we've received no additional funding for that. We're also asked to account for the money that is to be collected for providers to register under the new Act, which I believe this year is about $505. So we have to collect it, account for it, and be able to do our due diligence in accounting for the public's money.
Now, I know I've talked with the Governor from Arizona, being from Arizona. We've got some difficult circumstances. How would you see that? Could you see us working more collaboratively or more, how do I say, from a State's vantage point versus what the Federal Government's dictating?
I believe that the States are probably the best resource that we have right now in combating fraud, waste, and mismanagement. And as in my testimony, I spent 22 years with the Federal Government as a Federal agent and a supervisory special agent, and 11 years currently with the State Medicaid program. We are the best equipped to fight the fraud because we are closest to it. We know what's going on in our States. We work collaboratively with our health care programs. We worked with the managed care system, and I believe that increasing the Federal match, such as right now the Medicaid prosecutors receive 75%, and we, the OIG, receive 50%. And I believe matching that and making it at least equal with the prosecutor would be a wise solution to the program.
So one size fits all doesn't work?
Not really. So
we're really too big as a Federal program. Should we go back to the States?
That's my belief.
Mr. Cannon, one of the aspects of medicine is defensive medicine. Can you talk to me a little bit about tort reform and how we can look at tort reform as the overall cost and why we haven't had any tort reform, particularly last year and years before?
There's a lot of belief that defensive medicine is driving wasteful health care spending. There's some evidence to suggest that it is, but I think it's important to recognize that there are two types of defensive medicine. One is efficient defensive medicine, so that if the let's take the example of back pain. Should everyone with back pain receive an MRI as a matter of course? Well, if it turns out that not giving those patients an MRI results in injuries to them, they suffer losses because we didn't detect serious spinal injuries, that would exceed the cost of providing those MRIs. Well, then, yes, we should provide those MRIs. That's efficient defensive medicine. So there's also inefficient defensive medicine where the cost of not providing them those MRIs is not that great, maybe because we don't have many good treatments for back pain, in which case the cost of providing the MRIs would exceed the whatever losses they would suffer from not receiving them. So it's very difficult, first of all, to tease out the inefficient stuff from the efficient defensive medicine. And important to distinguish between the two, but it's also difficult to discern whether it's the fear of lawsuits that's driving the use of more and more services, or is it the fact that in this country, as a result of mostly federal policy, most doctors are paid on a fee-for-service basis where they make more money the more services they provide. Both the fear of lawsuits and fee-for-service payment are pushing in the same direction. So I'm not sure that it was, first of all, very difficult to figure out how much defensive medicine is contributing, inefficient defensive medicine is contributing to wasteful health care spending. But I believe that it's not a significant factor. I think that the fact that the Federal Government subsidizes health care so much through the Medicare and Medicaid programs and the tax code plays a much larger role. Now, that said, I think that we do need serious medical malpractice liability reform in this country. Why have we not seen it? I think the biggest reason is that judges will not enforce contracts that allow individuals, either with their health care providers or through an insurance plan as an intermediary, to set their own, to decide, basically to pick their own medical malpractice liability reforms. Judges won't enforce those contracts. I think that's a much superior approach to trying out things like caps, loser pay rules, and so forth, because if something doesn't work, it's much easier for patients to rewrite the contracts than it is for the Federal Government or State governments to rewrite the laws once they've been put into place.
Hold that thought. We'll come back for second round.